Okay. So I guess we'll pick up from where we were. And hopefully we'll have a little bit of time at the end. We can revisit our stuff for Monday. And try to see how accurate you guys were. So we stopped on Wednesday talking about increases in lactate threshold. We're talking about the kind of muscle and metabolic adaptations to aerobic training, how all of that's going to work. Kind of in that stuff that leads to increases in lactate threshold, our ability to have more mitochondria and more capillaries is going to be a fiber type conversion. Okay. So just like with resistance training, we go from 2X's to 2A's when we do any kind of training. And the big deal about why this is important, right, is 2A's have a very, very, very increased capacity to hold mitochondria. And that's the big deal. Okay. So that's going to be one of our other things that's going to help us out a whole lot as we try to add those. All right. So I mentioned this on Wednesday, but I want to kind of formalize what was here. But as you become more trained, okay, as you become more trained, you decrease the use of carbohydrates at all times, and you increase the use of fat. Okay. So people that are better trained are better at metabolizing fat. And essentially, because you're better at using fat, you don't have to use the carbs. You don't have to use the carbs. Okay. And so what happens then functionally is I use more fat. I don't use muscle glycogen, so it stays around longer. Okay. I also don't use as much blood glucose, so it stays around longer. So by not using glycogen, by not using blood glucose, then that's one of the sources, right? One of the sources of central fatigue. So by using more fat, it helps me prevent fatigue. Okay. Also, then it lets you eat more Chick-fil-A, which is great. But from a performance standpoint, that's going to be this. So what does this look like if we had you connected to the metabolic cart? Okay. Those of you all, if you've had exercise testing and prescription, or you've had exercise physiology lab, you've had one of those two classes, you guys have seen someone hooked up to the metabolic cart, right? You all remember that? Some of you are looking at me like, no, you haven't had those classes yet. But if you have, right, you breathe into the mask, and it spits out for us oxygen consumption, it spits out RER and those things. Okay. So if you take a person who is trained, right, or they were once sedentary and now they're trained. If you have them, if they weigh the same, okay, if you have them walk on a treadmill at say 3.5 miles an hour, trained or untrained, their energy expenditure to move their body, so their VO2 is going to be basically the same. Okay, it's going to be basically the same. If they jog at 6 miles an hour, it's basically the same. And so what we see at the same absolute work rate is that when you are more trained, your VO2 is the same. Now, if you change your running form and you get better at that, then maybe you can become a little bit more efficient. But in general, all that the training does is it raises the top end of everything. Okay. Nope, that's not going to work. I don't like that. Here's oxygen consumption, and then here's running speed or something. It looks like this. And then when I'm more trained, it's basically the same. All that I can do though is it raises my top end. I can actually run at higher and higher speeds. It lets me do this. Okay. So RER though will fall. At any given place that I am along all of this, RER falls, which indicates that I'm using more fat. Okay. And less glycogen, less blood glucose. Because I'm using more fat and I have a lower RER, that also means I have a chance to make less lactic acid. Okay? So that's one of the kind of ways that having more mitochondria, having more capillaries manifests and helps prevent fatigue and let us exercise for a longer time and at higher work rates is because it shifts our substrate utilization. And that shifts some of the things that might cause fatigue. Okay. So, as I had said, the big issue about why that happens is about mitochondria. There's just more. Okay. And there's a greater place for it to go. Interestingly, and for the most part, you guys have done pretty well with this on the last set. Remember that one of the things that we do when you exercise to alter substrate utilization to maintain blood glucose is to increase the release of epinephrine and norepinephrine, right? That leads to glycogen breakdown. To be honest, it also leads to the breakdown of free fatty acids and those things, which kind of drive a little bit of lactate. What we do see in people that are better trained is that any given work rate, you have less release of epinephrine and norepinephrine. It's less stressful in that way. Okay. And so that is going to prevent a little bit of additional glycogen breakdown. Okay. So, but the really, really big thing that drives all of it, it's mostly just increased mitochondria. Okay. Okay. So how do all of those changes lead to an increased performance? We get less fatigue and long duration exercise, less glycogen depletion, right? What we're going to see here, increased use of fat. So this becomes sort of why we can go a little bit longer. One of the reasons that all of you could, if you really wanted to, if I ran behind you with like a cattle prod or something, I could probably get most of you all, I don't know that all of you could run a marathon today, but you could go that far, like you could cover that distance, but you feel really shitty by the end, okay? And so as you become more trained though, you're going to use less glycogen in these things, and so you'll feel less shitty as the whole thing goes on. Okay. To be honest, anybody that ever runs a marathon, it's terrible, right? Like it's completely terrible. It's just a kind of a degree of those things. Okay. And don't really worry about short duration kinds of stuff. We better able to offer hydrogen. Some of this is stuff that we haven't actually really covered and talked about. This is a big deal from a fat perspective. Okay. Okay. So let's talk about adaptations in the respiratory system. There's really not. So I told you guys the other day, I think last week when we were talking about sort of pulmonary systems, there are almost no adaptations, okay, in that system because that system is rarely ever limiting. So it's really difficult to overload that system and get it to adapt, okay? So if we measure sort of your breathing or your ventilation at rest, when you're trained versus untrained, basically no differences, okay? Your VE is basically the same. Rest per minute's the same. Your tidal volume is basically the same. During submaximal exercise, as long as you're under lactate threshold, your breathing looks exactly the same as well, okay? No changes there. Above ventilatory threshold, so once you clear lactate threshold, okay, ventilation is going to be a little bit lower at any given absolute work rate or percentage of VO2 max. So you become a little bit better. Primarily, this is due to the decrease in lactic acid production. Okay, so a little bit of changes at kind of higher intensity submaximal exercise. And then what we see at max exercise is much like what we see with oxygen consumption. It's essentially the same, sort of the same graph. Okay, if it was to be ventilation. If when you are untrained and we do a max test and you stop here with ventilation, as you become more trained, what happens is just that your max VE goes up. Okay, it's going to go up. And so as it goes up, this is not so much a training effect. It's just that your other systems allow you to work harder and harder, which lets you tap into this increase, this further increase in ventilation that all of you guys have sort of right now. Okay. Okay. So we'll quickly, sort of run through the pulmonary system because I don't like it. So let's talk about cardiovascular system. One of the big things that's fascinating to me that happens as you train is you get more blood. Okay, you get more blood. So what we could do is I could ask you guys to try to line yourselves up by who we think is the most fit in class. And we put you guys in order in here and do that. And based upon that, the person that's the most fit probably has the most blood. Which is kind of a weird, strange horror movie type of thing going on. But total blood volume increases. That's the big thing. Okay. As blood volume goes up, you're going to get more red blood cells and you're going to get a corresponding increase in plasma to go along with all of that. Okay. And I'll show you a thing about the time course of that. But generally, plasma volume goes up first. And then red cell count is going to lag by a week or two after all of that, and then it will eventually catch up. Okay. The cool thing about this, anybody do aerobic exercise where you probably did some level of overloading yesterday? Show of hands. Anybody? All right, like the 4 of y'all. Okay. What are we doing, guys? Right. Meet me today, 1 o'clock at the Huff. We'll all go run. Okay. But like the 4 of y'all that did that yesterday, there is a chance you have an increased blood volume today compared to where you were yesterday. Okay. And so the way that blood volume increases, I don't know where I heard this term. It's not in a book or anywhere, but somebody called it this, and I thought it made really, really good sense. So I put it up here for you guys in red. The changes in blood volume are due to a thing that we will term a persistent acute effect. Okay. And so by persistent, I mean that it stays, you're constantly getting this acute effect. But what happens is you go and exercise, you raise your blood pressure, you drive plasma out of the blood, okay, into cells, you get a little pump. So blood volume falls, you raise blood pressure. It weirdly also actually drives an increase in urination because blood pressure. Right, you guys know that your kidneys are arguably the biggest regulator of the blood pressure in your entire body, even more so than your cardiovascular system. People that have kidney failure and problems like that, what kills them is sometimes their kidneys, but a lot of times it's hypertension. Anybody super salt sensitive, like you eat a bag of Lay's potato chips and it makes your blood pressure go up like 10 millimeters of mercury? No. Okay. Anybody have Jacob Matney as an instructor for testing prescription? Okay. Bring Jacob salty chips. If Jacob eats something salty, his blood pressure will immediately go up. He's very, very salt sensitive, and it's all regulated through the kidneys. So what happens is you exercise. Remember from our hormone day, you get an increase in antidiuretic hormone and an increase in aldosterone. Okay. The sum net effect of those things is that we overcompensate. You drink more water and you retain more water and more sodium, which also leads to retaining more water at the kidneys. And so your plasma volume goes up. Okay. Your plasma volume goes up. You ran yesterday, it goes up today. It will stay around for a couple of days. Okay. 48 to 72 hours. If you don't exercise again, right, today or over the weekend, by Monday, your plasma volume you'll basically have peed out the extra plasma and it will have returned to wherever it was yesterday-ish before you exercised. Okay. So it's a small increase, but if you exercise yesterday, it's up today. Exercise again today or tomorrow, and it goes up a little bit more. And then you wait another couple of days. As long as you are every couple of days exercising consistently, this acute effect persists. Okay. It persists week over week over week. And so then eventually blood volume has gone up. Okay. Blood volume is going to go up. Now, Plasma volume goes up really quickly. There's actually been a couple of studies where they have done this and they have people go and they'll exercise. They can measure this small increase in plasma volume, and then they do a VO2 max test like 2 days afterwards, and they can measure, it's right at about the error of measure in the metabolic curve. They can show this small increase in VO2 max after like one bout of exercise. Really, really cool. Okay. So it looks roughly like this. Here's why blood volume is so important. On the left side here, okay, we have a person's maximal oxygen consumption, so their aerobic fitness level. So less trained at the bottom, more trained at the top. Here we have their blood volume normalized to body weight. So it's in milliliters of blood per kilogram of body weight. This is the reason we normalize to body weight. Let's just compare across people that are different sizes. And look at this. Very, very kind of linear increase that people that have higher levels of fitness have a higher blood volume per body size. Okay. And that's mostly because the training that you do to help increase VO2 max drives an increase in blood volume. We'll get to in a couple of slides, though, why having more blood actually is helpful for VO2 max. This graph shows if you are consistently or persistently inducing that acute effect with exercise, it's going to show changes in total blood volume, in plasma volume, and then in red cell count. Okay. And they're all graphed as the same percent change. We start off here at 0. Okay. This bottom one is what happens with red cell volume. So it takes somewhere between 2 and 3 weeks to a month to see this sort of noticeable increase in red cell count. You'll see this giant increase in plasma volume early on, and then it kind of comes back down. And then actual blood volume is going to kind of fall back. So in these people, they got about a 10% increase in all of these things. But you get plasma volume early, and then red cells lag, and then the plasma volume kind of equilibrates back to its red cell count. So once we get out here, your hematocrit percentage tends to not change. Early on in training, it actually goes down. You have fewer red cells as a percentage of your total blood volume, which isn't great. But after about a month or so, your hematocrit percentage stays roughly the same. Okay? So you have more blood, which lets us carry more oxygen, but your hematocrit percentage kind of equilibrates out. This is not the same as if you are Lance Armstrong or any other probably competitive endurance athlete of his era, and you are a blood donor. What they would get is some expansion in this, but they would get a more pronounced increase in red cells. So you get an increase in blood volume. You also get an increase in hematocrit. And that's why that is such a powerful, powerful way to increase VO2 max in endurance performance. All right. Does that make sense, guys? Do you guys follow kind of what's going on here? More water in your blood, which is good, which we'll talk about why that's going to be the case. The answer is always preload and stroke volume. Okay. And then red cells are going to lag behind. Okay. So let's look then at what about arterial venous oxygen difference. Okay. Like a lot of different things, ABO2 difference, remember, is our ability to extract oxygen from the blood. So it's in many ways dependent upon capillaries and blood getting to the muscle, but also on mitochondria being able to pull that O2 out and use it. No real changes at rest, no real changes during submaximal exercise, right? You need whatever oxygen you need. That part's not going to change. If you weigh about the same, at the same sort of work rate, the energy cost is the same. But we see an increase in ABO2 difference during maximal exercise because you have more mitochondria, you have more capillaries, you have a greater cardiac output. So it lets you get more O2 to the muscle and pull it out. And that's why max is gonna mostly go up. Okay. Again, it's not a pure kind of adaptation. It's just a consequence of these other things that let us sort of draw more out. That's what we're going to call. Okay. Blood pressure. If you are a person that has normal blood pressure, exercise training has basically no effect on your blood pressure. Okay? If you're already normal, it doesn't get more normal. It doesn't make it go down even more so. Okay? However, if you're a person that is hypertensive, chronic exercise can make it fall by about 10 millimeters of mercury. Okay? So, and that decrease most often is seen in systolic pressure, but sometimes we'll get a little bit of a drop in your diastolic pressure as well. This is why one of the first things that they suggest for people that are either pre-hypertensive or that are hypertensive is exercise more, cut out sodium in your diet, and let's see if we can get blood pressure to fall with that before we give medications, before we try to do it. Okay? You may ask, Dr. Black, how does it go down? We got no fucking clue. We don't know. Honestly, we don't know. Maybe it's because of decreased sympathetic nervous system activity. Weirdly, blood volume goes up. Usually blood volume increases tend to drive increases in blood pressure. It happens really, really quickly, kind of again, a persistent acute effect. So it happens before there's any sort of remodeling in our blood vessels, which we'll talk about in the next few slides. So we really don't understand, but it's very consistent in most people that are hypertensive. It will make your blood pressure fall. So for many of you, again, I'm like your parents, but I'm like, wait, your parents are like me in some ways, right? I gotta ask, okay, I'm just gonna ask this. How many of y'all have parents that are in their 40s? Yeah, man, that's what I was afraid of. Okay. All right. Your parents that are my age, basically are, should be more active if they're hypertensive or if they're pre-hypertensive. There's probably some of you in class that are mildly hypertensive. In class this size, we usually have several. You got systolic pressures in the 130s, and those places, y'all would benefit from some level of exercise as well. Okay. Okay. Now we're going to talk about what happens to arteries. Okay, to arteries. There's a process that is called arteriogenesis. Okay, arteriogenesis. This is going to be increasing the size, increasing the diameter of arteries. Okay. One of the big things with exercise training is your arteries get bigger. Your aorta gets bigger. Your brachial artery gets bigger. Your femoral artery especially gets bigger, okay? Which allows more blood to move through them. This is achieved through a process called vascular remodeling, okay? Vascular remodeling. Exercise increases, we're going to call it the lumen or the inside space, okay? And it decreases wall thickness. What you see here, this is one of my, I think it's a really, really cool graph. That's why I put it on it's a great visual, okay? This is data from a whole bunch of different exercise and also sort of unloading or sort of making people sedentary types of things. What you're going to see here is the change in femoral artery diameter. So femoral artery, put the Doppler ultrasound on there, measure the size. You have here on the far left, okay, you've got people that have had a chronic spinal cord injury. They have about a 30% decrease in femoral artery size in comparison to, say, a baseline or sort of an untrained person, okay? You can see here, as we train for 8 weeks, 12 weeks, and we see endurance athletes, right, that femoral artery diameter increases with training. Here's 1 week of lower leg passing, 4 weeks of lower limb suspension, 4 weeks of bed rest, 7, 9 weeks of bed rest, 3 weeks of a spinal cord injury, right? Complete inability to move does really, really terrible things here. And so what you see is as I become more sedentary, it falls. As I become more active, it increases. Okay? It increases. And then this is the sort of same setup, but it's showing the femoral artery wall thickness. The thickness of the wall is related to development of high blood pressure, development of atherosclerosis, and development of cardiovascular disease. And so as you can see, right, training makes wall size go down, being less active, right? Bed weak, spinal cord injury, these kinds of things. It's going to make it wall thickness go up. Okay, so this is this process of what we call arteriogenesis. It's driven by essentially when you exercise. I should have put a video. I should have asked Dr. Keller once live if they had a video. I'm sure I could have found one online. But if you watch people when they exercise and you watch their large conduit arteries, every time the heart beats, the artery goes boom, 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 and it expands out and it stretches. Okay. As you exercise, it also vasodilates, but then you can still see that surge from systolic blood pressure. You can see it expand like this. And there is something about that stretch and expansion of those things, the increase in blood velocity, drives the increase in some growth factors for blood vessels. And so why does training make this happen? Well, it induces these periods of high stretch and high velocity through those arteries, which then leads them to remodel, so they'll stretch less the next time, et cetera, et cetera. Okay. Now, you don't have to know any of the stuff on here. Again, I just like to show you guys that there's this very, very complicated signaling mechanism, right? Which you're going to get this stretch from the increase in blood pressure every time the heart beats. You're going to get shear stress from the increase in blood moving through. And what this does basically is it activates this thing here called NOx2, right? Which then leads to the production of nitric oxide, which then eventually will lead to the production of something that I love what it's saying is called VEGF. VEGF stands for vascular endothelial derived growth factor. And it's basically VEGF. You put VEGF on an artery and it will make it bigger. Okay. So there's this complicated mechanism, but again, it's mostly exercise that does this. There are other things that do this as well, though. Okay. The group of people in the world that have the lowest incidence of cardiovascular disease are Scandinavian countries. Okay. Now, they're the most active of everything, which is you might think is a little bit backwards, right? It's dark 6 months of the year, right? They're the healthiest. They have the highest quality of life, the highest standard of living. They also have the highest rates of depression. And suicide rates, because it's dark 6 months of the year. For those of us that are having a hard time with the change, the time change where it gets dark at like 5, just imagine no light during the year. But they do something else. It's very, very common that leads to increases in blood vessel size and is helpful for blood pressure. You guys know what that is? You guys had to pick something. Don't cold plunge. Don't listen to Andrew Huberman. That part's full of shit. Okay. Don't get a cold plunge tub. Go get in a hot tub. You want to get in the sauna rather than getting in the cold tub. Okay. You get in the sauna, raises blood flow and these kinds of things. It's really good for the heart. Okay. And so countries where people, especially men who are at high risk of cardiovascular disease, especially men that get in the sauna all the time, have a much lower incidence of heart attacks and cardiovascular disease than sort of corresponding men in the same kind of places that don't. And so because it raises blood flow and these kinds of things, you get some remodeling and stuff from all of that. So what you heard me say was take a hot bath, get a hot tub, right? At the end of all of those things. Okay. So that's better than the cold plunge. The cold plunge will wake you up, but I'm not sure it's doing you a whole lot of other things that are particularly scientifically supported. Okay. All right. There's another, we already talked about this, but I want to give it the formal name. Okay. You also, in addition to the big arteries getting bigger, you're going to increase the number of capillaries. That process, so making an artery bigger is called arteriogenesis. Making more capillaries is called angiogenesis. angiogenesis, okay? This is making new fibers or more capillaries per muscle fiber. It's very fiber type specific. You get a lot more on 1s and 2As, right? And again, it's stimulated by basically the same factors that make the big arteries get bigger. If we are increasing those things and we're forcing more blood through the existing capillaries, they will start to branch off and we'll make more of these, okay? This is a really, really powerful thing for making VO2 max go up because it slows blood flow. It allows us to decrease the diffusion distance for oxygen and nutrients and lactic acid so we can get more stuff in. We're better at getting stuff in. We're better at pulling stuff out, okay? And that helps us limit fatigue. So more mitochondria, more capillaries, bigger arteries. Okay, bigger arteries. It's a fascinating graph from the guy on the left here. His name is Bengt Saltin. He was Swedish. One of the 2 or 3 most famous exercise physiologists the world has ever known. But these are all data from like the 60s and the 70s, but they published it out in 2011. This is max VO2 on the x-axis. And here's the number of capillaries per muscle fiber. This is from a whole bunch of different studies and a whole bunch of different people. But what you see basically is as capillary density increases, it's very, very, very highly predictive of this increase or having a higher VO2 max. Okay. And so capillary density very related to aerobic fitness. Same graph, we did it for mitochondria. It all kind of looks the same. And so having a greater ability to get oxygen into the muscle is really, really helpful. Okay, now we're going to end basically by talking about what's happening with sort of some of our central circulatory things. Heart rate and stroke volume are going to have opposite things happen to them for the same reason, okay, with exercise training. As you become more trained, resting heart rate falls. Resting heart rate falls. It falls because stroke volume increases. So the cardiac output that you need to supply blood and nutrients and oxygen to your muscles at rest, as stroke volume goes up, if cardiac output stays the same, it lets heart rate go down. Okay. So with training, you get about a 15, and some people you get even more, maybe 30 or 40 beats per minute decrease in heart rate. A lot of that is driven by the increase in stroke volume, which is due to heart size increase, but you also are going to get essentially people that are better trained are less stressed out. Okay. They have an increase in parasympathetic outflow at rest and a decrease in sympathetic outflow. Okay. And that lowers that parasympathetic input on the SA node, lowers the intrinsic firing rate of the heart. Okay. So we're using less energy than to pump the same blood. Stroke volume goes up, mostly due to an increase in left ventricle size. As you train, the heart gets bigger, especially the left ventricle gets bigger. The inside of it gets bigger. Okay. This is what we call cardiac hypertrophy. As heart rate falls due to some of this, it also increases the period of time we spend in diastole, which allows for more filling time. We have an expansion of blood volume, which means more blood volume, we get greater venous return, which also means now we get greater preload. So we have more blood coming back into a larger lumen with more time for that blood to come in. We get more stretch, it's a bigger heart, stronger hearts, all of those things together mean stroke volume increases. Okay, stroke volume increases. That's one of the big cardiovascular adaptations as well, is this increase in stroke volume. So I want to talk about cardiac hypertrophy really quickly. Again, what you see here is just kind of an example. I'll explain to you what all is going on. But there are 2 kinds of cardiac hypertrophy that take place. Okay, there's the kind that takes place with exercise training, which we call eccentric hypertrophy. The left ventricle gets bigger because when we exercise, we force more blood in and we stretch that heart, we stretch that ventricle a lot. Okay. So it drives what we call eccentric contraction hypertrophy, which means the space on the inside gets bigger and the walls of the left ventricle stay nice and stretchy and thin. Okay. That's the good kind of cardiac hypertrophy. The bad kind of cardiac hypertrophy is what we call concentric hypertrophy. Okay. And I should say that eccentric hypertrophy is due to what we call volume overload. It's a venous return, a blood volume overload stretching the heart, which is what happens during exercise. Pressure overload or concentric hypertrophy is due to high aortic blood pressure. If you have high blood pressure, the left ventricle has to contract more forcefully to raise the pressure in the ventricle above aortic pressure to get blood to leave. Okay? And so that is due then it has to concentrically contract more forcefully. And that's going to lead to hypertrophy, but it's like hypertrophy in your quads or your biceps or what we think of as regular skeletal muscle hypertrophy. The muscle gets bigger, the muscle gets thicker, okay? But the volume inside the left ventricle stays the same. It doesn't get a corresponding increase. And because it gets thicker, it's less stretchy. And so this is sort of dangerous or bad or maladaptive cardiovascular hypertrophy. Okay. It leads to higher blood pressures. It leads to greater chances of electrical disturbances in the heart, and it can be very dangerous. So that's the thing that we're talking about. If you hear people that have what's called a hypertrophic cardiomyopathy, an enlarged heart, the primary reason that they have that and it's bad is that they've had concentric or pressure overload hypertrophy that's taking place. Some of it is actually genetic, especially in folks that are y'all's age. For my few of y'all that are athletes, so they do echoes and check heart size on all of y'all. They do it every year. They used to did it when you came as a freshman, right? You can tell, like if somebody shows up at 18 and they have hypertrophic cardiomyopathy, then like that, it's a genetic kind of driven thing. And so we've gotten better at doing screenings and things for a lot of that. But every year you will see people that are very, very fit athletes, right? There was a guy that like a few years ago, he basically crossed the finish line in the Chicago Marathon and then had a heart attack immediately. He'd finished like fifth or something in the deal. And he had hypertrophic cardiomyopathy. So it was sort of a genetic thing that's going on. Okay, so at maximal exercise, cardiac output goes up because stroke volume goes up. Training has no effect on your max heart rate. If you're 20 and your max heart rate is 200 and you train a bunch, it's not going to go up to 210 or back to 220. It's going to stay basically the same. So max cardiac output goes up though because of the increase in max stroke volume. Right? It's all related to FIC. Max VO2, max stroke volume goes up, max AVO2 difference goes up because of mitochondria and capillaries. Therefore, max VO2 can increase. Okay? Everything can come back to this. You can explain so many things from this. Okay. All right. What's the time course of change in these? Well, we see an almost immediate increase in VO2 max, likely because of expansions of blood volume. Mitochondrial content, new capillaries, new red cells are going to take several weeks because they're all driven with protein synthesis. Okay. So mitochondrial content, maybe 3 weeks or so, we can see 2 to 3 weeks, we can see increases in mitochondrial content. Red cells take 2 to 4 weeks, depending upon like where we catch you in a cycle, and then capillaries are going to be kind of the same sorts of things. Okay? But the quick increase in VO2 is all from expansion in blood volume, all from plasma volume expansion, leading to a little bit of an increase in venous return, making cardiac output go up. Okay. Most of you guys can make your VO2 max go up maybe 15 to 25 or 30%. Okay, so you're an average college-aged male, your VO2 is 40 mLs per kg per minute. It's pretty reasonable that if with good training, you could get to be in the high 40s or about 50. Similarly, ladies, if y'all are at like 35, getting into the low to mid 40s is about where we are. Some people are super responders, right? You might be 40 or 45 right now, and you can get to be 65, 70. Okay. It can go way, way up. A lot of the people, though, that are very highly trained start off very high. Just genetically, you have a lot of mitochondria. You already have a large heart and blood volume for your body size. You're already up on that top end of things. So when you train, it's all you're kind of already above everything. 40% of the variability in the adaptations in VO2 max are genetic. There's some fascinating studies on identical twins and on people in the same family, like training. We're going to take you and all your mom and dad and your brothers and sisters and train everybody. And y'all's responses will be much more similar to each other than you would be to people in other families. And then they do like identical twin stuff. And it's not all exactly the same, but it's very, very close. There's some really cool stuff. So we know that about 40 to 50% of this is going to be on all of this. Some of you train as much as you want, VO2 max isn't going to go up. Your health will improve, but your VO2 max won't go up very much. So I can make all of you much better distance athletes, but I can't make all of you really, really good because there's some genetic stuff that goes in there. Okay. All right. Questions? Comments? Concerns? Should we do something really quickly to give you guys credit for being here on a Friday? Yes. Okay. What should that be? Anything? I want to put your names on a piece of paper, turn it in, be like, yes, I was here, Dr. Okay, let's do that. Let's do that. All right. So guys, next week we're going to cover exercise in the heat for a couple of days. Then we're going to do body composition and altitude as we get towards the end of class. Okay. I will have your tests on Monday. Who we got in football this week? All right. You guys have a good weekend. Be safe, make good choices. Or make bad choices. I don't know. Whatever.